Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN. Healthy you, healthy nation, healthy world. I'm Nancy Valentine, PhD and registered nurse. And this show is dedicated to you, the healthcare consumer. And to that point today, I want to introduce our special guest, who's a friend and colleague of mine, Denise Murphy, who works at Mainline Health. And Denise and I had the distinct pleasure of working together at Mainline Health and did some really amazing work in that joint venture together. So I want to tell you a little bit about Denise, because she is here this week, which is National Patient Safety Awareness Week, March 4th to 11th. Now, this show will not be broadcast during that particular week, but I want to keep it in mind, because it's a very important week for a lot of people who are in healthcare, like Denise. So let me tell you a little bit about Denise to get our show moving. Denise is a Philadelphia girl, born and raised in Philadelphia, and she got her nursing degree at St. Joseph's Hospital School of Nursing and LaSalle. And then she ventured forth to Portland, Maine, where she got her baccalaureate degree, and then she went on to St. Louis and got a degree in the School of Public Health. Now, Denise's current job at Mainline Health is she is the Vice President of Quality and Patient Safety. A very, very large footprint in an organization with 5 hospitals. But today what we're going to do is really talk to Denise about how she got started in her professional discipline of patient safety and quality. Now, this is the kind of work that you will hear that often goes on behind the scenes, something that you as the consumer may not be aware of. But to know someone that has really made this their life journey is really, I think, a great story and something that you will find extremely interesting. So welcome, Denise. It is a distinct pleasure to be with you again and to have this opportunity to hear about your life as a career, as a nurse, and how you got involved with this to begin with. Because most people start out in nursing, as we all did, you know, thinking of the bedside work. And you were telling me earlier that you were an intensive care unit nurse, that Denise worked with pediatric clients. She did a lot of work with airway support, little tiny preemie babies, and really then started noticing some differences. Some things came to her awareness that really impacted her career choice, and therefore is really going to make your life better. So Denise, let's start with you.
Thank you, Nancy. This is really an honor to be here, especially during National Patient Safety Week. So when I was a nurse at St. Christopher's Hospital for Children, one of the things, we had a tracheotomy unit. So that means, you know, people need sometimes support to breathe with a metal or a plastic tube. So we had a lot of tiny little babies. We opened a tracheotomy unit so that we could watch them all at one time. And we found that often there were little, what I'll call outbreaks or clusters of infections. So gastrointestinal things, you know, go through nursery schools and grade schools like crazy. And so I got to know the infectious diseases physicians and the people that specialized in infection control, which today is more referred to as infection prevention. It's an illusion to think we can control anything, right? So I was very interested in that at the time that I was working with small children with airway problems who depended on a tube to breathe. And if they developed any kind of an infection, especially pneumonia, they were really in trouble. So that spiked my interest. But after a marriage and first baby and, you know, moving to another state, I thought, gosh, what am I going to do with my career now? So there was a position open called a nurse epidemiologist. I had no idea what a nurse epidemiologist was, what that title actually meant. But I thought, well, this is an adventure, and it will allow me to look at a different area of nursing. Instead of helping one patient at the bedside and having a one-on-one relationship, it gave me the opportunity to work with populations of patients. So epidemiology is the study of disease and risk factors in populations, especially populations that are at particular risk for something. So during my first month in this new job and reading a stack of information, I came across a flyer from Harvard They were doing a workshop inviting the Centers for Disease Control, and this was on a new infection that nobody could understand and a new cancer that nobody could understand. So young, otherwise healthy men were coming up with horrible pneumonias that they could not find the right treatment for, they couldn't find the cause. At the same time, a very unusual cancer, Kaposi sarcoma, was showing up on the West Coast in otherwise healthy young men. So we have people in New York and people in California coming up with these really frightening infections, and they found that these infections were attacking their immune system. This was the start of the AIDS epidemic.
Well, let's stop right there. First of all, what year was that?
That was 1981.
1981, and I think when Denise was telling you what epidemiology is, it is the study of the course of diseases, and many times epidemiologists are studying diseases that we already know about, and they're trying to learn more about a given disease. But the example that Denise is giving us is epidemiologists are really like sleuths. You know, they really have to get out there in the field, so to speak, and try to figure out, how about these new symptoms? How about these new problems? What is it? How is it happening? Why is it happening? Let alone what can we do? You know, what could be the intervention which comes after that? So you are really on the forefront of learning about what epidemiology in the field really entails.
Absolutely, absolutely. And it was really frightening because, as you mentioned, we didn't know the cause of AIDS. We didn't know if it was a virus, if it was a fungus, a bacteria. What was it? Was it a cancer? And actually, it's all of those things. The syndrome that makes up HIV/AIDS is really a syndrome of lots of these things. People's immune system become very weak, and so the virus does that to you, and then they're, you know, really at risk for other types of infections.
Now, can I ask you, where were you practicing at that time?
I was in Portland, Maine.
You were in Portland, Maine.
In Portland, Maine, but luckily a drive to all of the Harvard centers, which you know well, and worked down there in Boston at the same time, actually, and it was a really frightening time. So there I was in a hospital trying to figure out, what is this new disease? How do we care for patients when we don't know how it's transmitted? The fear in society, and many people will remember that, was just horrific. But what that did was introduce me as a nurse to what today we so focus on, called patient-centered care, patient and family-centered care. So imagine families of young people who were dying of a disease that nobody knew what the cause was and there was no treatment for. But the way this played out in the community was the fear was so extensive that when a young, healthy, otherwise healthy person just deteriorated and died rather quickly, funeral directors were so afraid to take the bodies of these people with a disease that we didn't know how it was transmitted and embalm them or give them a viewing or a beautiful burial, which we all deserve. People in the hospitals, like in an operating room, so a patient is up there getting prepped and ready to go in the operating room, and all of a sudden the information comes out, well, you know, I've just been newly diagnosed with, at the time it wasn't even called AIDS. It had so many different names. But so as a nurse, I would get called by these frantic people, either in the hospital or in the community. And so it gave me an opportunity to really understand what prevention looked like on the front line, Nancy. People were scared to death. These were smart people who were passionate and dedicated their lives to healing, and all of a sudden they were deathly afraid, will I get this and take this home to my wife, to my newborn? It was really very frightening. Gave me the opportunity to get to know many people that were living with AIDS and their loved ones. I volunteered to be on many of the support groups to facilitate and lead support group meetings, and so my two little boys had to often come with me. These were in the evenings. I didn't always have childcare. And so they would say to me, Mommy, what are you talking about? How can drugs make people sick? What does sex mean? That was the most frightening thing.
And how old were they?
They were little, really small.
So,
you know, first and second grade.
Jump-started that conversation.
Right. But, you know, the bottom line is that it made me understand that our work at the bedside about providing clinical care is one aspect of what a nurse does. And the other side of that is the spiritual care, the emotional care of the patient and family, which today gets a lot more press than it did back then. But we were going into high schools and then convinced the town to finally let us into junior highs. I mean, from a public health perspective, people were becoming sexually active and experimenting with drugs as young as 12 years old. High school's too late to teach prevention. So young men and women that were suffering with HIV/AIDS would come with me into the schools and teach young people about the importance of prevention. So as a young epidemiologist, it was an incredible journey for me and led to my deep understanding of prevention, my further studies about epidemiology. And you know, when you look at medical errors and the outbreak, if you will, of medical errors that we became aware of when the Institute of Medicine published To Err Is Human back in 1999 and started to show that when people come into a hospital, our commitment is to keep them safe. But they were getting infections, they were getting pressure ulcers or skin breakdown, they were falling. They were having medication errors. So to bring this epidemic of errors, human errors, to the forefront was really wonderful. So you can see where a career in epidemiology would take you beyond infections to the study of all types of medical errors.
That's a very good point. Well, first of all, let's go back. You were, again, looking for sort of your next step in your career, and you saw this conference, and it was really just out of curiosity that you went to see, you know, what that was all about, and that conference basically sparked your interest.
It did. It sparked the interest, my interest, but it also put me with a whole group of healthcare providers across the country that were dealing with an epidemic of fear. So much of the early literature on AIDS does speak to not just the epidemic of an infectious disease that was fatal at the time. And today people are living long and healthy lives with HIV/AIDS, but they weren't back then. They were dying quickly. But the epidemic of fear was what kept healthcare providers from wanting to go into the rooms of patients with this disease and from wanting to bury them properly for funeral directors, school teachers. When we started to see, remember, young kids with hemophilia that were receiving blood transfusions with infected blood, and the Red Cross really was incredible in this country in terms of early in that epidemic, recognizing the need for testing of blood and protecting the country from the spread of HIV through transfusions.
I think I'd like to just really capitalize on a couple of the key points that Denise is really making clear to us. First of all, epidemiology is not a word that easily rolls off the tongue, and not everybody has even heard of the word epidemiology. So we want you to understand that there's this whole cadre of people, doctors, nurses, other scientists that really are out there studying the course of illness. They're not necessarily a cardiologist, or they're not your family doctor. Those folks are focusing in on disease management of certain disorders. These people are really, again, looking at the course of disease and trying to figure out what the best interventions are. That's a whole study in itself, and something that we have to be incredibly grateful for, that there are people that are really interested in that. And the point about it being a culture of fear, as you all recall, you know, having lived through that for most of our listeners, it was really also highly politicized. So not only were there people trying to find out, like, the nuts and bolts of what is this illness, what are the causal factors, what should we even call it, what is the diagnosis, so to speak, then, you know, what can we possibly do to, you know, intervene? And that wasn't clear for a number of years. It got highly politicized because of the type of people that tended to get this illness, having to do with homosexuality, drug use, especially using needles, and then it got contaminated to people who weren't either homosexuals or using drugs, but getting blood transfusions, like Denise said, young children, you know, anyone that was getting a blood transfusion was literally open to some risk with this early on.
Our country learned very quickly that, remember the days when we used to pay for blood donations?
Yes.
So IV drug users would go to donate blood in order to get money to buy drugs. And so we learned very quickly that the blood supply in the United States was getting contaminated, and immediately the Red Cross and the government took action. But the most wonderful book, called And the Band Played On by Randy Schultz, is really a story of the early AIDS epidemic. And epidemiology is the study of epidemics. So it started in London with John Snow connecting the horrible plague that killed so many people in Europe with the Broad Street pump, you know, that everybody went to. The pump handle was contaminated, and that's the only place the community could go to get their water. So epidemiology has a very, very long history, but I think Nancy's point about when you go into a hospital to know there is a team of physicians called hospital epidemiologists. They're most often, infectious diseases physicians by background, and a team of nurses and microbiologists and public health experts who have the title infection preventionist. And those are people in the hospital that are there to work on protecting you every day. Those professionals are in the hospital, they're in the community at our health departments, they're at our public health clinics, so they're really everywhere, but I don't think most people know that these people are in hospitals, so I really appreciate you bringing that up. Patient safety specialists are also people who are nurses and physicians who dedicate themselves to the study of medical errors and the analysis of medical errors and how do we prevent these things from continuing. And it blends many different sciences. Of course, all of the sciences of medicine and epidemiology, human factors engineering, what causes humans to behave the way they do or not comply with safety behaviors. And for anyone who's been on 15 diets in their lifetime, it's really an interesting study of what makes us as humans do the right thing or do what's a little bit easier, even if we know there may be consequences. We never think it will happen to us.
Well, that's important because after you had the drama of dealing with the AIDS epidemic, your career really went on to the day-to-day work in a hospital, really helping to reduce and prevent infections. Tell us about you know, your day-to-day world. What's it like?
I will, but I do want to mention, as you may remember, Nancy, that what it was like for me in my 22nd year as an infection preventionist, which as a nurse epidemiologist, that's obviously the titles have changed over the years, and now it's an infection preventionist. But in my 22nd year with that as part of my background and being certified in that field, but broadening at that point into being a patient safety and quality officer, I watched my own mother die of a healthcare associated infection. And some of them are preventable and some of them are not. And I think that's very important for the public to know, is that there are three things that come into play in preventing infection or preventing any kind of adverse event or error or outcome less than desired. So it's in epidemiology we learn that the triangle is the host or the patient, the agent, which can be a bacteria, it can be a virus, it can be a mold, anything that can make us sick. And the third thing is the environment. And when you look at the healthcare environment, especially if it's a hospital, and you think about not only the human interaction, some patients could report that they see over 100 people a day, or they have over 100 human interactions. So there could be 20 or 30 different people that they see and over 100 interactions that they experience during the course of any day. But if you add on top of that technology, equipment, the complexity of diagnosis and humans, albeit the best and the brightest and totally committed healthcare providers interacting with a sick and frightened patient and their family, it really creates a very complex environment. And we have the very best healthcare system in the world. Despite our flaws, we still have the best healthcare system anywhere in the world. But it is humans caring for humans, and all humans make errors. And so that's what the study of patient safety and reliability science, that is delivering the same care, the same results, the same way in every environment to every patient that warrants that type of care, is really about studying reliability. So doctors and nurses are not trained in the science of reliability in our schools. We're working to change that. And but it's a very needed team of professionals. So thank you so much, especially during this particular week where we're trying to raise awareness, to let our community know that these people are out there to help you, to be your partner.
One of the reasons we're wearing our flowers is that this is part of the National Patient Safety Awareness Week celebration at Mainline Health and throughout the country. It's a national event. I also think it's really important to also remember Dr. Everett Koop, who died just a few weeks ago. Dr. Koop, as you recall, if you again lived through the AIDS epidemic, really made a tremendous difference in our country because of the stand he took, which was really not politically correct at the time. But he said that we have to stop blaming people and we have to start intervening. We have to start taking preventive measures. Dr. Koop, by background, was a pediatrician and very well trained and a very humanistic person who made a huge difference for us in our country by, again, building that awareness and really helping people to understand, to get over the fear and to take really positive action.
Right.
But you know, I'm thinking about your mother. That must have been really tough, Denise, to be in the field, be working, you know, all the time to really prevent infection, and then have to really see, in the case of your mother, having, you know, to deal with that personally. I mean, how did that go in terms of what happened to her?
Well, it was devastating, but it happened to be one of those situations where the infection aspect of it was not preventable because we were just on the cusp when my mother needed emergency heart surgery. It was actually the year that the FDA approved the new testing of all blood products that people are transfused with. So it was before we were able to find infectious diseases that contaminated the blood. And they came out, my mom had heart surgery in early 1990, and later in that year, they came out with a test that identified hepatitis B, hepatitis C, which is what my mother developed.
From the blood transfusion.
From the blood transfusion that she needed during her heart surgery. So that's the infection side of it, and that wasn't preventable. But the patient safety side of it was preventable. Patient safety is largely about good communication and good teamwork, keeping our awareness up and looking for risk all of the time. My mother, over the next several years, started to demonstrate multi-system organ failure. No one picked up the fact that she actually had hepatitis, and she had hepatitis C, which treatment came out while my mother was ill, but the awareness wasn't there. Physicians didn't think of it, and they actually told her when she went to donate blood that she had hepatitis A, which was the wrong type of hepatitis. If we knew she had C, we could have gotten her treated. Hepatitis A goes away. It has a lifespan, and it's not infectious after you go through, you know, a typical period, but her diagnosis was misread by several teams of healthcare providers that cared for her. I was, of course, under the assumption that she had a type of gastrointestinal hepatitis that would have a lifespan that went away. So as her heart and lungs began to fail and her liver and other organ systems, we were looking down the wrong road. We were looking for other causes for heart disease, lung disease, liver disease, when in fact hepatitis C was just slowly killing her. So it's about communication, it's about teamwork, it's about the partnership of families. I asked several times for, do we have the right hepatitis panel? Can we retest her?
Which means, just for our audience, just explain when you say the hepatitis panel, what that means.
Hepatitis panel is looking for, hepatitis is a disease of the liver, but since our blood is filtered through the liver, it's understandable why people with certain types of hepatitis, they'll carry that in their blood. If it's undiagnosed, if hepatitis C is undiagnosed, then it will start to cause a failure of all of your organs. So when you ask for a hepatitis panel, you're asking for testing of all the different types of hepatitis because they have different treatments related with them, and my mother was misdiagnosed. So when I mentioned to Arizum in the 1999 study that the government supported over 36,000 patients in only 2 states in this country, their medical records were pulled, and what was looked for was any type of adverse outcome of healthcare. So that's where we were able to start to categorize that wound infections, falls, medication errors, pressure ulcers, and most importantly, missed diagnosis and delayed treatment, which is the medical error that you would categorize my mother as having, misdiagnosis and delayed treatment. They started to raise awareness about that, and then the real study, the government put money into it, and during the Clinton administration, the Agency for Healthcare Research and Quality was developed. We really started to deeply study the causation of these errors. Why do they keep happening? What are the preventive measures that we can put in place? And so now we really are, many years after the AHRQ was developed, we are in a better place in patient safety. So for example, we have reduced bloodstream infections in this country by over 60%. And in the state of Pennsylvania, we've reduced bloodstream infections by almost 60% in the last few years.
I would just have to say that you were already passionate, Denise, obviously, about your field. But with your mother experiencing, such a tragic death, along with many thousands of other people, like you say, she was just on the crest of some of these advances, but her timing was just not, perfect for all these advances to have kicked in. That must have fueled your passion even more for what you're doing.
It certainly did, and it made me more aware of all of the advocates that are not healthcare providers in the community. So of course we have the Consumers Union. That's a big national advocacy group for patients, but in every community, and in this community on the main line, in the city of Philadelphia, it's unbelievable the number of advocacy groups that have joined in partnership with physicians and nurses, technologists and therapists to really understand how do we as partners prevent medical errors. And it is not always a medical error. Sometimes it is just understanding the risk factors. So infections can largely be prevented, especially if they're device related. So central lines are lines that go into our bloodstream, and some of the complex ones go all the way into our heart to monitor specific things in our blood that are very important to one's recovery. But these things carry a risk with them. And so these are more preventable. Infectious diseases that come into the hospital and spread to people that are immunocompromised often depend on human behaviors, like hand hygiene, like ability to comply with isolation precautions, which you'll often see a sign on the door in hospitals. If you're a patient or you're a visitor, you'll see signs, and we're trying to protect people that have infectious diseases, but we're also trying to protect the people that don't have them. But the human factors issues are so critical that the partnership with our community, with our patients, so that they're aware of risk factors, they're aware of the prevention measures, and that they become spokespersons for themselves, and they partner with us. We have a job as healthcare providers to keep people safe, but I believe that everyone has a job to understand what places them at risk for certain bad outcomes when they're sick, even if they're in their home, under the care of a physician, or especially when they're in the complex environment of a hospital. So maybe we can talk a little bit more later about what that partnership really looks like.
We certainly can. I think that the takeaways from this discussion today for you, the healthcare consumer, is for you to be aware that there is a lot of work being done every day in every organization. We're talking about acute care applications primarily here, but really epidemiology and people that are really trying to do quality improvement, any kind of safety, to prevent any kind of error is really happening throughout the healthcare system and community settings and doctors' offices as well. So I think that that's important to be aware of. I think secondly is to realize that it's science that makes the difference. It's one thing to be afraid of something. It's another thing to really delve in and get the information, because the more information, if you're in the healthcare field, obviously that's our job. But even if you have something that you're afraid of, it's important to get the information to understand the science and back of what is your prescription, your course of illness. I think, and thirdly, what Denise is saying is that you play a role in your quality improvement and your safety as well in hospitals. And we are going to have other shows in this series that are going to address each of those areas very specifically. So I want to thank you for being with us. Denise, you've been a tremendous guest. I mean, her enthusiasm is infectious. I know from working with her, she's a great nurse, and she has made a tremendous contribution to this community. And I want to thank you, our listeners, for being with us today. Join us again. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.